So I don't think we actually put together any questions, because at the end of the day, we thought we had enough material and we would just allow you guys to ask questions as opposed to us putting cases up here.
Did you show them something?
Oh, yeah, yeah.
Okay.
Yeah.
Can I just have your, I'm sorry. Go ahead.
Just a question about seeing all these combination therapies for both men and women using, like, for example, Flomax with Ditropan or Detrol. Just when is it the right thing to do? When is it the wrong thing to do? Always a concern about men having urinary retention, they have like prostate using some of these products.
Sure. Well, the correct time to do it is whenever you have multiple problems, because you're really treating two different things. Certainly men can get an overactive bladder just as women can have problems with overactive bladder, and that's the time you might try an anticholinergic, antispasmodic. And there's a whole flavor of those. But you got to remember that as soon as you start to relax the bladder or take the hair trigger off of it, it's not going to squeeze with as much force, which means it won't have as much oomph to empty out, and your post-void residual urine volumes can go through the roof. So if you're going to put a man that has any signs of obstruction on something that's going to relax the detrusor or the bladder muscle, you have to monitor their post-void residual urine volumes. There's nothing that says you can't put somebody on an alpha blocker and something like Detrol or whatever, Sanctura, whatever medication you'd like to try, just with that caveat to watch the PVRs, because you're really treating two different things. It's not that uncommon to develop an unstable bladder. Remember, we talked about the whole osteopathic idea that if you obstruct the urinary tract, the bladder responds by becoming more powerful. It hypertrophies, and when a bladder hypertrophies, the wall becomes thicker. And thick-walled bladders don't like to stretch, just like somebody who's over-muscled but didn't stretch when they were working out. The bladder won't stretch, so your capacity goes down at the same time that your post-void residual urine goes up, so you can sort of get hit from both directions in that way. But you can use both medications together. It's not unreasonable.
I just see a lot of retention with people using both.
Well, the problem is and that's absolutely true. The thing is, they probably had some component of retention or increased post-void residual urine volume to start, and that's why they're on the alpha blocker for their urinary tract obstruction. It's like, because there's a pretty wide gap of what's considered normal PVR. Anything less than 50 of a PVR, post-void residual urine, what you leave in your bladder after you void, less than 50 we think is normal. Anything over 200, that's a pretty wide functional range, because the normal bladder holds between 350 and 500 to start. We talk about these PVRs. In reality, if you're normal and healthy, your post-void residual urine volume, we used to laugh and call it bladder sweat. It's just a couple of cc's. It really empties out well. A couple of years ago, we had our patients start coming back from spring break when they go down to Florida and they go to Walt Disney World, and they'd come back and they'd tell us that they'd passed kidney stones. It happened once, happened twice, didn't really think a lot about it, until I started actually asking my patients, soliciting information, saying, hey, you were on spring break, what did you do? And they said, I went to Disney World, and I was asking this of all my patients that were stone formers. And what we started to notice was there was a pattern that people who went to Disney World had a high rate of passing kidney stones. Okay? So we followed this up a little bit further, and we found that we were actually able to implicate a specific roller coaster at Disney World. Okay? So this started as an offhand comment from one of our patients, just talking to them and getting ideas. So what we actually did is we needed to come up with a model or a way to test this theory. And this is where it really got interesting. What we did is we took one of my patients that was a stone former, we did a CT scan, and we took his CT scan and we turned it into a stereolithographic program of 3D imaging. We took a 3D printer and made a model of a hollow part of this guy's kidneys, of his kidney. So his calyx, his pelvis, and his ureter, we made a 3D model of it. This model was accurate to within 0.3 millimeters. It was a very accurate model. And then what we did is, since he'd had kidney stones in the past, he kept his stones. So what we did is we had a model developed from a patient that makes stones, and we actually had his stones. So we took this three-dimensional hollow part of a kidney, and we embedded it inside a clear silicone block, which is what this little thing up here in the corner is. So what we were able to do is take his stones and insert them into different calyx. We could put them in the top calyx, the middle calyx, or the bottom calyx to see what would make the stones pass.
So as I saw the poster, I thought it was interesting. So, but he was post-lithotripsy.
Post-lithotripsy. So this was, this model was made from a known stone former, and we had his stones post-lithotripsy that he had spontaneously passed. We filled the model up with urine, and we were then able to take these little fragments of stone and insert them into different calyxes. Okay? So what we're showing you here, in the initial pilot study, we had 3 fragments of stone in a single model. So we put his 3 stones in different places in the kidney and went for a ride on this roller coaster 20 times. And this is actually the passage rates. We were able to show that we could pass stones in a test fashion, but what was really interesting is we were able to show that if you want to pass a kidney stone, your success rate is best if you ride in the rear car, okay? You can pass any size stone from any calyx, okay? But here's what really was kind of fun about this. You have to have a relatively low impact roller coaster, okay? If you go and ride something, say, at Cedar Point that has a lot of high-speed turns, what happens is your stone fragments get trapped into the calyx by centrifugal force. They won't fall out. What makes this little coaster down at Disney World so unique, it's called Big Thunder Mountain, in case any of you have kidney stones. It only goes about 30 miles an hour, only lasts 2.5 minutes. It's supposed to look like a runaway mine car. But if you've ever been on it, it makes phenomenally fast turns. It goes up and down, it goes right and left, and there's a place where the track's supposed to be out of order, and it's kind of like rumble strips. And what we found was that you could pass stones of any size, any shape, any calyx, particularly if you rode in the rear car and you exploited that particular ride. Yes, sir.
You ride this majority next by cycle?
Yes. Well, the first time I went down and rode
Repeat the
20 times.
question.
Sorry?
Repeat the question.
Oh, he asked how exactly we carried the model. The first time we did this, we actually just had one model, and we put it in a backpack and sat it between us in the car. The roller coaster is 5 cars long, 3 rows of seats, 3 wide. So we would put it between us on the roller coaster in the backpack, sitting on the seat. Now, as we got fancier, if you look at the numbers from your distance, we actually did 174 stone trips. We spent a lot of time on this roller coaster. It's kind of like being in a car wreck by the time you get off of it at the end of the day. But we picked up 174 data points to prove that this would in fact work. And at the end, we actually got to the point where we had 7 different models, all of which were the same hollow patient. The duplicates of the model was the same, but we wanted to know what happened based on kidney stone size. This was our first study, 20 rides on the roller coaster with 3 fragments of stone.
Who cares?
This was an additional set of rides, both in the front of the car and in the rear of the car, but stones that were everything from a grain of sand less than 5 millimeters up to stones that would have been about 6 by 6 millimeters in size, which is about the biggest thing that anybody can spontaneously pass without getting stuck at the UPJ. So the take-home message is, if you have a kidney stone that's passable, this may help you dislodge it before it continues to grow and get big enough where it gets stuck. I'm absolutely serious about this. If you have any of your patients who have been subjected to a lithotripsy, they've had an extracorporeal shock with lithotripsy, a urologist has crushed their stone, but they have retained a fragment, put them on this coaster or something very much like it, because the vibration dislodges the fragments before that little piece of sand can become a nidus and grow into a big kidney stone. The reason I'm proud of this is it just happened from listening to our patients.
Don't they have to take 20 trips on the roller coaster?
No, in fact, one of the patients that came back that convinced me that this was worthwhile, he came in and he goes, "Doc, I passed a stone, you're not going to believe it happened." I asked him for the story. He went on the coaster, he got off, he passed a kidney stone. He went and got on it again, passed another stone. Went on a third time, passed a stone. So we have good actual anecdotal evidence from our patients that this does not require 500 rides. Now this is a big deal. To pass kidney stones in the past, if y'all see what's called the teeter hang-up, it's a gentleman that sells an inversion table for low back pain. Basically hang by your ankles and the table swings 180 degrees into a vertical position. Trying to pass kidney stone fragments so you don't make new stones is such a big deal that they've actually done research where they've hung people in inversion tables, hydrated them, and then done percussion on their back trying to knock these stone fragments loose. So this actually may matter. I'm also telling you this because I'd love to do this with human beings, where we can actually take an x-ray of somebody before they go on spring break or before they go on summer vacation and see if they actually pass stones. Does this really work in the real world?
Well, that roller coaster is also very good for scaring the hell out of a 10-year-old boy, which I did myself.
Now, by way of, this data was collected in 2009, okay? So why am I just not getting around to publish it? It's a legal issue. I was afraid that if I published this data back in 2010, people who had their vacations ruined because they had a stone passed, went on it, had a kidney stone, didn't know it, stone got stuck in the urine, and they got their vacation ruined, would be upset with the Disney company, okay? Well, I didn't publish it until the statute of limitations is run out, okay? And also, this roller coaster, as it existed for this research, has been remodeled. So the coaster, as it existed in 2009, no longer exists, so there is no issue. But I would love to go back and double plate mate and see what else we can do. Thank you for indulging me. This I just thought was kind of an interesting little example of we build a model, we tested it, and more importantly, we talk to our patients. Thank you.
Congratulations for winning the poster.
Thank you.
Last minute Friday afternoon questions.
You indicated sphincter repair does not generally work. How about a person who had rectal surgery and the sphincter over years becomes very lax? Is there a mode of improving that sphincter so that it will retain feces, which gets, let's say, loose or not well formed?
Yeah, good question. Talking about retaining or treatments, other treatments for fecal incontinence, if the sphincterplasty is not necessarily the greatest operation we have, first thing you got to make sure is that they're neurologically intact. Do they have a sphincter with sphincter tone? If there's no tone at all and there's a very complex piece of equipment that you have to have in your office to figure out whether or not their sphincter's got good tone or not, and it's called your finger. It's been studied before and it's just as accurate as any of the manometers that are out there on the market, but your finger can do a pretty darn good job. You've done a digital exam on many normal people, so you understand what weak and strong is. The problem is if you're not getting much tone, there's not a whole lot we can do to make the tone better if there's neurologic damage. However, physical therapy with biofeedback is very helpful and has been very promising to make things better. And it's try to help them understand how to use the muscles and hopefully build the muscle up. But if there's neurological damage to that muscle complex, you're not going to be able to get it better. And that's where all the work with stem cell research is coming out and these other gizmos we have to try to tighten up that sphincteric mechanism. Does that answer your question?
Yes. Where would one go if I refer a patient to, let's say, have stem cell, let's say the neurological is intact and stem cell may be helpful to them? Where are they doing this type of research or procedure?
If they're neurologically intact, you can actually help them with physical therapy.
Okay.
You definitely can. If they're not neurologically intact, that's the problem. We don't have, a sphincteroplasty can be done, but you got to let them know that you may not get much improvement and not long-term improvement from this. And the problem with the sphincteroplasty is it's got a tissue breakdown fairly high. A lot of wound healing issues, especially if they're having this problem. They may have diabetes as well, another reason for them to be neurologically inadequate. So it gets to be a problem with that. If they're neurologically attacked, there's a lot we can do with simple physical therapy. Without the neurologic sphincter tone, that's more of a problem.
Todd, can you expand on what physical therapy techniques you're talking about?
Sure. Physical therapy techniques that we use for fecal incontinence are very similar to what we use for urinary incontinence as well. The difference is we add biofeedback. Like I was telling you, probably cramming at the end there. Well, biofeedback is using something called anal rectal manometry. These are tests we do to measure different pressures that are inside the rectum, the anal sphincter, the actual rectum itself. And there's a balloon on the end of that you can actually inject liquid in, and the patient can actually sense when they're full, when they feel like they have an urge. And with time, you can actually improve their ability to actually improve the sensation, so they know that bowel movement is coming quicker. Fecal impaction is a problem in the elderly, and it's because they lose that sensation of rectal filling. Well, anal rectal manometry, again, if they're neurologically intact, can actually help them sense when their rectum is full quicker, so they can actually empty their bowel before it gets a chance to become impacted. Quite often in the elderly, when they're leaking liquid stool, it's because of fecal impaction. The solid stool is filling up the rectum, and the liquid stool is sneaking around it. And you're getting that inhibition of the internal anal sphincter because the rectum is full. So it's a double-edged sword. So trying to get that impaction out of there is definitely paramount.
And trying to get patients to understand that.
And trying to get patients to understand that, yeah. And a lot of times their medications are contributing to this. This is part of what's going on.
Because I've had a lot of patients that can't understand, how can I have diarrhea and be impacted? And you have to sit and explain it to them. And
Right.
Finally, with time, you can get them to understand it and you get rid of their fecal impaction as well.
Fix the impaction, get them on more of a soft stool, and you'll fix the problem. Miralax is kind of interesting, PEG, or polyethylene glycol. It's not antifreeze, all the car got people out there, that's ethylene glycol, or ethylene glycol. But Miralax actually works fabulous. It's a safe medication, even though you go on the internet, it'll tell you that it'll also cause your taxes. It's also probably related to mesh. It's probably also, but it doesn't really, it's a very safe medication to use, and it works for both liquid stools and solid stools. It's a very good water absorber if you're having a problem with liquid stools. It gives them some substance.
And with fecal impaction, I found now they have milk and magnesia in tablets and tablets. So they don't have to drink the liquid. So you can get them to take it, and that works very well for the fecal impaction.
It does, yeah, if you have the impaction at the time. Miralax is not a treatment, it's a preventative. The idea is to keep things
But so
normal.
that, so if you have to take the milk and magnesia on a daily basis, because it won't affect your bowel at all. And
Right.
you take it on, and it'll keep them soft so they don't run into that. And you can get them to take the gel caps and tablets a lot easier.
Oh, absolutely, than that pasty stuff, yeah,
Yeah,
definitely.
take a drink of the liquid.
Dr. Boes has a question over here.
Yes, my question regards you that past term, that 30 to 60-year-old woman, and it's HPV positive, but the type B is negative for 16 and 18. You repeat the pap smear in a year for the guidelines as you look on here, and that's negative. Is it 3 years or 5 years if you do the HPV testing? Is it another year?
I'd have to go to the app, because I told you it got more complex. But I think that, so you have cytology negative, HPV positive, then you went genotype. So HPV positive, just for the sake of, if you're not doing this every day, there's 13 or 15 high-risk HPV subtypes that are covered when you do the HPV screen. And then you can genotype specifically for 16 and 18, which are the two highest risk ones, HPV subtypes, within the component of that panel of 13 or 15. So she was HPV 16, 18 negative, you said, correct?
Correct.
So I think the guidelines are to repeat co-testing in 1 year.
Correct.
Okay, and then what's the question after that?
Well, after a year, do you fall back to your previous?
Then I would fall back to the previous, yeah.
And let's say, I haven't had this happen yet, but let's say it comes back 1 year HPV positive, the titer 16, 18 negative. You do a colposcopy at that point?
I believe that per the guidelines, and I'm not 100% sure, I have to look at the algorithm, usually they give you two choices, and they'll say preferred, or, you know, if you're at all concerned, there's nothing wrong with doing a colposcopy just to get extra reassurance. I don't think it's, I'd look at that algorithm to see how to follow it, but at a minimum, I would recheck her again in 1 year. But if you said, you know what, I want to take a look with the colposcope because I know that if I see something light up, I can biopsy it, then I might go that direction.
Thank you.
You're welcome. It's gotten very complex. Yes, sir.
A lot of physicians will use permanent vaginal cream for urinary symptoms. Any validity to that, or is it placebo effect?
So, well, no, I think it's definitely more than placebo. I think there's first of all, there are many estrogen-rich receptors in the lower third of the vagina, the periurethral, urethral area, the bladder neck, as well as in the labia majora, minora. The things that have been found in the postmenopausal woman to be most beneficial, and Todd can chime in on this as well from his Urogyn standpoint, is, besides vaginal atrophy, is urinary urgent, they have urge, not urgent continence, but urgency, frequency. Estrogen cream will help with that. And also, I lost my train of thought, sorry. For chronic recurrent urinary tract infections. What's not been shown to be effective is for it to be helpful in urinary stress incontinence. There actually was a couple secondary analysis studies that kind of came out of WHI that suggested that hormone therapy, that estrogen therapy might actually make urinary stress incontinence worse. I'm not sure that I believe that. And it was a secondary analysis. It wasn't the primary endpoint of the study, but that has been discussed. But the clear things to be helpful are for the chronic UTIs and the urgency. But if you have urgent continence, I wouldn't hesitate to try it, but I don't know how much helpful it's going to be. Todd, do you have anything more to add to that?
No, I agree. I agree. It's if you help urgency, quite often you'll help urgency incontinence, just vis-a-vis. But for the most part, it does help with urgent symptoms, and I found it helps with urgent symptoms and recurrent urinary tract infections.
For the recurrent urinary tract infections, are you using 5 per year, or is there a specific number that you kind of recommend?
I don't know what the criteria are. I would defer to urology or urogyn for the exact criteria as to what's defined in the literature. But if I have a patient who I'm seeing and she's had more than a couple of urinary tract infections, she has atrophy, and that's happening, I always say, let's try this and see, and it's been definitely shown to be a benefit.
Dave, if I'm wrong, I think it's 3 per year or 2 per 6 months by AUA. AUA is 3 per year or 2 per 6 month, considering recurrent, with separation between the infections, not a reinfection of the same.
One final urological thought that I had, because I actually talked to Dave Wartinger about presenting this if it came up, if we did case studies, but I've seen more than once women present for quote-unquote postmenopausal bleeding, or what they believe to be bleeding from the vagina, presumably from the uterus. And certainly we have to look at that. We have to look at the endometrial stripe or sample the endometrium. We have to look in the vagina at the cervix for bleeding. But if all those things are negative, even if she thinks it's not from her urine, check her urine, see if she's got blood in her urine, and you may pick up an occult early bladder cancer that way.
Especially if they're a smoker.
Okay, thank you.